everyone. I'm Dr. Priyanka, junior resident from IMS Patna, and going to present a case series on Canaliculi involving lid laceration showing anatomical and functional outcome. There is no financial disclosure or no conflict of interest. Eyelid laceration involving the canaliculi has a prevalence of around 10 to 20% of all eyelid trauma, and the common modes of injury involve Blaujock fastener, animal bite, fall, blunt trauma, or RTA. The presentation is usually late and associated with other life-threatening situations, so the subsequent delayed repair leads to scarring and constriction of the lacrimal pathway, followed by lifelong symptomatic epiphora. It's more prevalent in case of children and young adults, with males more frequently affected, and the surgery involves primary suturing along with mono or bicanalicular stent placement. Coming to the methodology, over 6 months of period, we took patients with lid laceration with the canalicular involvement operated in IMS Patna. The distal cut end was identified as a pinkish white mucosal structure, followed by the Bowman's probe was introduced to look for a hard stop through the punctum. After that, a monocanalicular stent was used and along with pericanalicular suturing. The removal was planned at 3 months post-surgery and syringing was to be performed. The functional outcome was observed as absence of epiphora, and the anatomical outcome was observed as with respect to structural integrity and patency of the nasolacrimal duct. These are few of the pre and post-op images. As you can see here, this patient had a lower lid laceration with the canalicular involvement. We put a stent, and at 3 months of post-op, we removed the stent and the NLD was patent. This is a similar case with similar outcome. This was a child who had a trauma due to Blaujock fastener while being breastfed by the mother, and the similar procedure was noted. But these children had both upper and lower canalicular involvement with edema and late presentation, so we could not locate the puncta and only primary repair was done. Coming to the observation from my case series, lower lid involvement was more common rather than upper lid, with consisting of 10 out of the 12 cases. 4 toddlers had injury due to Blaujock fastener, which is quite unique to our country. And there was male predilection with 8 out of the 12 cases, and less than 18-year group consisted of 9 patients. The presentation and subsequent repair ranged from within 24 hours to 5 days post-injury, and the edema and inflammation in late presentation produced difficulty in finding the canaliculi and subsequent stent insertion. And coming to the results, at post-op 3 months, only 3 patients were completed and the stent removal was done. There was no regurgitation of fluid from the involved canaliculi. Premature pulling was present in case of one child and another was lost to follow-up. In case of pediatric patient, the absence of epiphora with stent in situ was taken as functional outcome, as they were not cooperative for syringing under topical anesthesia, and we cannot take them under GA for multiple times. Coming to the discussion, lacrimal canaliculi lacks a tarsal substructure and displacement from the cancel tendon increases the risk of tear. The preferably repairs should be done within 48 to 72 hours, but there is no clear guideline. The methods for locating the canaliculi we can identify as an anatomical landmark by elevated tubular structure, or we can inject fluorescein or air bubble. Fiber optic light probe can be used, or we can also use pictal catheter, but it is less commonly used these days as it is traumatic to the normal canaliculi. After that, stent insertion can be done. These are few of my related works and references. I would like to conclude saying that it needs skillful surgical intervention at appropriate time if there is no other comorbidity, and stent placement can significantly improve a patient's quality of life, and meticulous tissue apposition improves the cosmesis. There should also be awareness regarding safe breastfeeding in a country like ours. Thank you.
Just a moment, excuse me. You'll have to come back.
So you said the duration from trauma ranged from within 24 hours to 5 days.
Yes, sir.
So out of the 12 patients, you showed one patient in whom it was not possible.
Yes, sir. He presented after 3 days of trauma.
Any other patient in that series, or
No, most of the patient presented within 48 hours.
within 48 hours?
Yes.
And did the patient in whom the stent was lost or the stent was pulled out, did it have any effect in the final outcome?
He had symptomatic epiphora, but the child was only of 1 year of age, so we are
Syringing
waiting
was not done.
on the follow-up.
All right.
Yeah, and all the patients were used only silicone tubing?
Yes, sir. Ma'am, mini monoca stent
Only
was
mini
used.
monoca.
Yes,
And
ma'am.
you got any of the patient where you could not find the
There was
nasal
one
and
patient we could not find.
so what did you do in that?
Only primary suturing was done, ma'am, and the
Okay.
patient was kept on follow-up.
So for just the reference, we have got one Drishti canaliculostomy intubation set,
Yes,
which
ma'am.
where you can find the cut end of the canaliculus, nasal end of the canaliculus, as well as the stent is already there with that.
Okay.
That stent you can use in 10 patients. So that's very, very effective and very easy technique when
Yes,
you
ma'am.
don't have to use air bubble and fluorescein. And I tell you, it becomes mass when you're using any
Only
fluorescein, anything.
mini.
It doesn't work like that.
Thank you, ma'am.